everyone, this is Suprava. Welcome back to another session with me. In today's session, we will be dealing with a hemolytic disorder. So in this particular type of hemolytic disorder, it is, we can say that this is a disorder of hemoglobin, and basically there would be decreased production of globin chains. So our today's topic is thalassemia. So basically, in thalassemia, what we can see is that, the body would be producing enough amount of RBCs, but the quality of the RBC won't be good, right? So here, the quantity is proper, but the quality is not proper, right? So when do we say that, the quality of the RBC is not good? So as I mentioned earlier that this disorder is related to hemoglobin, right? This is a disorder of hemoglobin. Now when we say that this is a disorder of hemoglobin, we mean to say that, the hemoglobin would get affected somehow, right? So this hemoglobin is important. It's a very important part of RBC, and it's very important for RBC because it is an oxygen carrying protein, right? So if this hemoglobin is not formed properly, then definitely the RBC would it would get affected, right? So what happens in thalassemia is that these hemoglobins aren't formed properly, or we can say that it's not produced properly. So that's what happens in thalassemia. So we learned that thalassemia is a hemolytic disorder. This is inherited, and also here there will be abnormal hemoglobin, we can say, or the hemoglobin which are formed, it's not proper, right? So when we are talking about hemoglobin, and we are also saying that the hemoglobins aren't formed properly. So to understand that, let us learn about the structure of hemoglobin, or let's look a bit into the structure of hemoglobin. So normally hemoglobin is made up of 4 globin chains, and each of these globin chains are bound to a heme group. So there are majorly 4 globin chain types. Those are alpha, beta, gamma and delta. So based on these, which globin chain is binding with which heme group, and based on their combination, there are different hemoglobins. So there are different types of hemoglobin. Now first we have HbF, or we can say hemoglobin F, that is called as fetal hemoglobin. So this fetal hemoglobin is made up of 2 alpha globin chains and 2 gamma globin chains. And then we have HbA, or hemoglobin A, which is the major adult form of Hb, and this is made up of 2 alpha globin chains and 2 beta globin chains. And then there is HbA2, which is a very small fraction of adult Hb form, and this is made up of 2 alpha globin chains and 2 delta globin chains. So here we would talk about the fetal hemoglobin and the adult hemoglobin, that is HbA, right? Now what difference we can see between these two is that in fetal hemoglobin there is no beta globin chains, right? Because it is made up of 2 alpha globin chains and 2 gamma globin chains. Whereas in HbA, that is the adult hemoglobin, there we can see that it is made up of 2 alpha globin chains and 2 beta globin chains. So majorly in thalassemia, what we can see is that either the alpha globin chains would get affected or the beta globin chains would get affected. Now in fetal hemoglobin, we only have alpha globin chains, right? There is no beta globin chains. So there is, apart from alpha globin chains, there is gamma globin chains. And in adult form of hemoglobin, that is HbA, we have 2 alpha globin chains and 2 beta globin chains. So as only these alpha and beta globin chains would get affected, we would talk about the alpha globin chain and the beta globin chain here, right? So if we see hemoglobin A, that is the adult form of hemoglobin, that has 2 alpha globin chains and 2 beta globin chains, right? Now how these alpha globin chain and beta globin chain is made up of. So if we see the alpha globin chain, it has 4 genes and the beta globin chain has 2 genes. Now what we mean by that it has 4 genes or it has 2 genes? Now it has 4 genes means 4 genes are combined together to build this alpha globin chain. Whereas for beta globin chain, 2 genes are combined together, or it's there are 2 genes which made up this beta globin chain. Now we know that when a baby is born, they receive 50% of the gene from the father and 50% from the mother. So if we talk about the alpha globin chain, that means 2 of the genes, the child will be receiving 2 genes from the father and rest of the 2 from the mother. Whereas if we talk about the beta globin chains, then there we have only 2 genes. So that means 50% from the father and 50% from the mother. So that means 1 gene from the father and 1 gene from the mother. So here, if in case, for example, if the child receives any mutated gene here, then the child would become the sufferer, or the child will get the trait of thalassemia. Now, when we are saying mutated genes, that means among these, 2 genes from beta globin chains, if any of the genes is mutated, or if the child receives any, faulty gene from the father or from the mother, in that case, the child will have the trait of thalassemia. So next, let us move on to the definition of thalassemia. So thalassemia is an autosomal recessive disorder characterized by genetically determined reduction in the rate of synthesis of normal globin chain. So here, let us first, learn about the first sentence, that is saying thalassemia is an autosomal recessive disorder. Now, what we mean by autosomal recessive disorder? Well, autosomal means it is not related to the sex chromosomes. Now, that means it is not, the mutated gene is not carried by the X chromosome or Y chromosome. Instead, it is carried by an autosomal chromosome, right? So, when we are saying that it is not related to the sex chromosome, that means it doesn't matter whether the newborn baby is male or female. Whereas if we talk about hemophilia, we have already learned that hemophilia is a sex-linked disorder, right? So in sex-linked disorder, what happens? The mutated gene is carried by the sex chromosome, that is the X chromosome or Y chromosome. So there it would definitely depend on the sex of the child, whether the child is male or female. But in this case, in autosomal disorder, it doesn't matter whether the newborn baby is a male or female, because here the faulty gene is not in the sex chromosome. Instead, it is there in the autosomal chromosome. And then we are also saying that it is an autosomal recessive disorder, right? So what do we mean by recessive? We understood about autosomal, right? Now, recessive means, now let us take an example, right? So here, if we take the beta globin chain, so here we have 2 genes, right? So that means the child will get 1 gene from the father and the other 1 from the mother, right? That is 50% from the father and 50% from the mother, right? Now, for example, if here among these 2 genes, if one of the genes is, it's a mutated gene, right? And the other one is the healthy gene. So what do you think here? That whether the child will get affected, whether the child will be suffered, the child will get the trait of thalassemia or not? Yes, there can be 2 things. So if the child, develops the trait of the disease or trait of the disorder, in that case, we can say that this mutated gene is a dominant gene. Why we are saying this? Because here there are two genes, right? So for the other one is the healthy gene, right? But here what is happening? The mutated gene is overpowering the healthy gene, and it is causing the signs and symptoms. It is causing the disorder, right? So definitely that means this gene is dominant, right? So then we say it is an autosomal dominant disorder, right? But here we are saying that it is an autosomal recessive disorder. So when it is a recessive disorder, we can see that if one of these gene is mutated gene and the other one is the healthy gene, it cannot cause the disorder because it is not that powerful that it can overpower the healthy gene. So for these recessive disorders, what it has to be, both the gene has to be mutated, right? Then only it can cause the disorder. So that is what we mean by autosomal recessive, that it is not related to the sex chromosome and it is a recessive disorder. That means both the gene has to be mutated. One mutated gene and the other healthy gene cannot cause the disorder. And then we are saying it is characterized by genetically determined reduction in the rate of synthesis of normal globin chain, right? So that means the globin chain is not getting synthesized properly, right? So there is reduction in the synthesis of globin chain. There is not enough formation of globin chain. And we learned that, each of these hemoglobin are made up of these globin chains, right? So you can understand how important it is for the globin chains to form properly, right? So if these globin chains are not getting formed properly, there is reduction in the synthesis of the globin chains, then what would happen? There would be, the hemoglobins won't form properly, right? So they, again, the formation of the hemoglobin would also get affected. And in turn, if if the hemoglobins aren't formed properly, what would happen? The RBCs would get affected, right? Because this is a protein which carries oxygen, right? So if the hemoglobins aren't formed properly, then, it cannot carry oxygen, right? And the RBCs also cannot form properly. So that is how it gets affected. Well, so next let us move on to the causes of thalassemia. So we already learned that if there is a defect in the gene of any of these globin chains, that is alpha globin chain or beta globin chain, then that causes thalassemia, right? Now mostly we can see thalassemia in Mediterranean. Now why it is? Because if we see the incidence, so when thalassemia started, it started in that geographical area, in people who lives around Mediterranean Sea. So we can see mostly in them, and then apart from them, African and Southeast Asian populations also, they are also majorly affected with thalassemia. So people who live around the Mediterranean Sea, because of that geographical area, there was some mutation in gene. There was some sudden changes in their gene, and because of, that is how thalassemia started. Well, next let us move on to the types of thalassemia. So here, if we classify thalassemia, we can classify into majorly two types, that is alpha thalassemia and beta thalassemia. So first let us talk about alpha thalassemia. Now when we are saying it as alpha thalassemia, I think you can easily understand that this is, this happens due to deficiency of alpha globin chains of hemoglobin, right? So here, somehow the alpha globin chain is affected, right? That's why we are calling it as alpha thalassemia. And we know that there are 4 genes in alpha globin chains, right? So if any of these genes are missing, or it is mutated, then the synthesis of the alpha globin chains can get affected, right? And that is why we are calling it as alpha thalassemia. Now we know that there are four, genes in alpha globin chains. So if one gene is mutated, then we call it as, carrier, because we know that this is a recessive disorder, right? We already learned that what we mean by recessive disorder. So we know that this is an autosomal recessive disorder, and if one gene is mutated, that cannot cause the disorder, right? Because it is a recessive gene. So if among these four genes, if one gene is mutated, then the child will become carrier. So in that case, the child will not have any signs and symptoms, and the child is not actually affected with thalassemia. And if two genes are mutated, in that case, it is a form, it is a case of mild to moderate form of alpha thalassemia. And if there are three mutated genes, then that means it is moderate to severe form of thalassemia. And then if there are, among these four genes, if all the four genes are mutated, in that case, the child is severely thalassemic. It is extremely rare condition, because here what is happening, the child is receiving 50% gene from the father and 50% from the mother. So if the child is having all the four mutated genes, that means the child has got two mutated genes from the father and two mutated genes from the mother. So that's the reason all the four genes are mutated here. So you can understand that how severe it would be. So there is high chance that there would be stillbirth. That means, the child will die inside the uterus itself. And even if the child is born alive, then what would happen, even after, within few days after the delivery, the child will die, because the child cannot survive in this case, because all the genes are mutated and the child will be severely thalassemic. And the next type is beta thalassemia. So beta thalassemia happens due to deficiency of beta globin chains of hemoglobin. So here, as we discussed about alpha thalassemia, and we learned that if there is deficiency of alpha globin chain, we call it as alpha thalassemia. Likewise, here if there is deficiency of beta globin chains of hemoglobin, we call it as beta thalassemia. So here in beta thalassemia, again we can classify it into two types, that is beta thalassemia major and beta thalassemia minor. Now we know that beta globin chains has two genes, right? Now when beta thalassemia major happens, so when these two genes are mutated, like all of these two genes are mutated, we call it as beta thalassemia major. So in this case, so what is happening? The child is receiving, the mutated gene from both the parents. So the child is getting one mutated gene from the father and one more mutated gene from the mother. So that's the reason the child will be here beta thalassemia major. Now this is an extremely, it's a very severe form of thalassemia, and this is a life-threatening condition. And here in beta thalassemia major, we can see, there would be severe anemia in the child. And also this is, beta thalassemia major is called as Cooley anemia. And then there is thalassemia minor. So here in thalassemia minor, what would happen? The child would receive one mutated gene from only one parent. So the other gene would be healthy. And as we have already discussed that, it is a recessive disorder. So both the gene has to be mutated. Now here in thalassemia minor, we only will have only one mutated gene. So that means, here mostly the child will be a carrier. So that's all about the types of thalassemia. Now next, let us move on to the clinical manifestations. So in clinical manifestations, again we would talk about alpha thalassemia and beta thalassemia. Now alpha thalassemia is it's less severe, and we can see mild anemia will be there, and the child will be basically asymptomatic. However, beta thalassemia is a severe condition. So here at birth, we can see the child will be normal, but eventually, the child would develop severe anemia. Now, why is that? Because, we have already learned about fetal hemoglobin, right? Where we have learned that there are only two alpha globin chains and two gamma globin chains. So there is no beta globin chains, right? So that is why this deficiency would not be evident, and that's the reason the child will not have any signs and symptoms at birth. So at birth the child will be normal, and soon after birth, when the child needs adult form of hemoglobin, the child would have severe form of anemia. Also, there would be pale skin because the child will have anemia. Now, the paler depends on the severity of anemia. So, if it is a mild case of anemia, then the paler will also be mild. But if it is a severe case of anemia, then we can see severe pallor in the child. And then there will be iron overload. Now, why iron overload? Because these children would need continuous blood transfusion, because their body is not able to make proper hemoglobin, right? So there is reduction in the synthesis of globin chain, so there is reduction in the synthesis of hemoglobin, and that's the reason we have to transfuse blood. So when we are transfusing blood, we are also providing iron, but the child might not need that. So might be the body might be producing enough iron. So in that case, there would be iron overload, and the child will have failure to thrive, or frequent infections, and also there will be splenomegaly. Now, why splenomegaly? Because the spleen helps to fight with the infections, and also the RBCs which are getting hemolyzed, right? So those RBCs need to be wash out from the body. So spleen does that. Now, because these RBCs are not formed properly, these RBCs are not, it's the quality of the RBC is not proper, right? So that's the reason hemolysis of RBCs would be faster, right? So the spleen has to work way too faster than normal, right? So that's the reason there would be enlargement of the spleen, and that's the reason there would be splenomegaly. Also, because of these RBC hemolysis, this rapid RBC hemolysis, there might be jaundice, and there might be bone deformities, especially in the face. And also there would be easy fatigability. So because there is not enough oxygen in the blood, right? So because of that, the child will easily get tired. And then there might be growth failure, because because of this anemia, the child will not have proper growth, so there would be growth failure. And also we can see heart problems. For example, there might be congestive heart failure, and also because of these things there might be pulmonary changes, because even though the child will be breathing enough oxygen, but then also there is not enough hemoglobin to carry that oxygen to the blood, right? So there is deficiency of oxygen in the blood, right? So these things would eventually cause pulmonary changes also. And then we can see radiolucent bone marrow with fine hair-like projections in skull X-ray. So if we take a skull X-ray of beta thalassemia major patients, then we can see this trait also, that is radiolucent bone marrow with fine hair-like projections. So these are some of the major clinical manifestations that we can see in children with thalassemia. Now next, let us move on to the diagnostic evaluation. So how we can diagnose, or how we can confirm the diagnosis of thalassemia. So definitely first thing that we would do would be history collection. So as a nurse, this is your first responsibility, to collect history, and through this we can get to know if there is any carrier in the family, or if there is any thalassemic patients in the family. That would give us a hint, right? So definitely the first thing that you would do would be history collection, and then you can do physical examination. So through physical examination, you can you can observe if there is pallor, or if there is splenomegaly, these things can be can be evaluated. And then we can also do a routine blood test, right? So here we can get to know if there is anemia, or it would also, if the patient is thalassemic, in that case it would also show that the mean corpuscular volume would be low, or there would be decreased mean corpuscular volume. And then through blood smear, we can see, the RBCs would be microcytic. It would appear small, and also we can see that it would be hypochromic. So it would be, there would be pallor. Then there is also a test called as hemoglobin electrophoresis. So through this procedure, they actually, they actually observe the hemoglobin, and they can differentiate the hemoglobins which are not normal. Right. So this can also tell us which type of thalassemia it is, and majorly, usually alpha thalassemia is diagnosed through this procedure. Then we can also do amniocentesis and molecular diagnostic tests. So these tests can, determine whether a mutation is present after 8 weeks of gestation. So if any of the parent is a carrier, or the parent is, thalassemic, in that case, it is, advised to go for these prenatal diagnosis, because that would help us to, evaluate if there is a chance of having a child with thalassemia, right? Now, most of the time, what happens, the people who are carrier, they don't even know that they are carrier, because, there won't be any signs and symptoms. So the people who are carrier, they are carrying the disease, but they are unaware about it, because there is no signs and symptoms, right? So that's the reason most of the time, the parent, or the mother or the father, they don't even know that they are carrier. So that's the reason it is always, nowadays it is advisable that even if you don't have the history of thalassemia, we don't know if the parent might be a carrier. So in that case, it is always safe to go for a prenatal diagnosis, so that we can evaluate it at much faster, and we can also treat it much faster. Well, next let us move on to the management. So here first we will talk about the medical management. So here in medical management, the patients who are having who are thalassemia minor, for them they don't require treatment as such, because their symptoms are very mild, and they don't have that severe condition, right? So they might have mild anemia. So in that case, they don't require treatment as such. But for thalassemia major, treatment is very necessary, because that is a very severe condition, right? So for thalassemia major, what would be our goal of treatment? So when we are talking about management, first thing we have to know that what is our goal, right? So the first thing would be providing or supplementing the hemoglobin, because they don't have enough hemoglobin. There is decreased in the rate of synthesis of hemoglobin, so we have to we have to compensate that loss or deficiency of hemoglobin. And the second thing would be to alleviate the symptoms of iron overload. So we already discussed that these children would have anemia, right? We know that. Now when there is anemia, we have to we are giving blood transfusion. In that case, we are also providing iron, but the child doesn't need that, so there would be iron overload, right? So we also have to manage the symptoms, or we also have to alleviate the symptoms of iron overload. So the first thing is to provide adequate amount of hemoglobin to the child, right? So for that, we would definitely do blood transfusion. That is the first and foremost treatment of thalassemia, right? So blood transfusion we would give, and during the blood transfusion, we also have to remember that the child should not get any type of iron supplement, because the child is already, the child might be having iron overload. We have to manage that. So upon that, if we provide iron supplements, then that would worsen the symptoms, right? So we have to make sure that there is no iron supplements given to the child during this blood transfusion. And the next thing is ion chelation therapy. So this is a procedure through which they would insert chemicals in the child's body, and these chemicals would bind to the heavy metals, or if there is toxicity of heavy metals in the body, for example iron. So these chemicals would bind to iron, and it would remove that excess iron from the body. Right, so that is what is ion chelation therapy. So this ion chelation therapy is used for this iron overload, to manage the iron overload, and for this we can use deferoxamine, and also there is deferiprone. So these are the two medications which are used mostly. Also, the child might be given hydroxyurea, so that would help in synthesis of hemoglobin, or that would enhance the quality of the RBCs. Next, we would talk about the surgical management. So, in surgical management, the first thing is bone marrow transplantation. So, if we can find a donor with whom the HLA typing can be matched, the child's HLA typing can be matched, then we can go for bone marrow transplantation. In that case, this healthy bone marrow would produce healthy RBCs or healthy hemoglobins. So in that case, the thalassemia can be managed, right? So bone marrow transplantation is a surgical management, and then we can also do splenectomy. So splenectomy is done if there is splenomegaly, if there is the splenomegaly is excessive. So we know why splenomegaly will be there. So to manage that, splenectomy can be done. Well, next, moving on to the nursing management. So here in nursing management, first we would talk about the nursing assessment. So if you have a child with thalassemia major, in that case, what are the things that you should assess? So the first thing would be you should assess for severe anemia, and there would be splenomegaly, there might be hepatomegaly, or for frequent infections. So what are the signs and symptoms of thalassemia major, so you have to assess for that. Now if you have a patient with thalassemia minor, in that case you have to assess for mild anemia, usually with no signs or symptoms. So the child will not have any signs and symptoms other than mild anemia. Next, moving on to the nursing diagnosis. So here we will talk about the nursing diagnosis and the related factor, and based on your patient's condition you can add the evidence factor. Right now, the nursing diagnosis, the first thing would be ineffective tissue perfusion related to reduced cellular components essential to deliver pure oxygen to cells. So why there is ineffective tissue perfusion? Because we know that there is decreased production of hemoglobin, right? Next, there will be activity intolerance. Why there will be activity intolerance? Because there would, there is an imbalance of oxygen supply and consumption needs. Also, there would be imbalanced nutrition, less than body requirements, related to lack of appetite. So the child will have less appetite. Because of that, there would be imbalanced nutrition, less than body requirements. Well, next let us talk about the nursing interventions. So in nursing interventions, the first thing we would focus on the activity. Now here we've already learned that there is an imbalance of oxygen supply and the consumption needs, right? And that's the reason the child will be easily fatigued, right? So to manage that, we have to provide frequent rest periods to the child, right? And we also have to make the parents understand why it is important, why frequent rest period is important for the child. And also in case of thalassemia major cases, in those cases you have to assess the child in some of the daily activities, so that the child doesn't become easily fatigued. Next, you also have to prevent infection, right? So how you will prevent infection? The first thing would be assessing if there is any signs and symptoms which is indicating if there is infection. And the next thing would be you also have to instruct the parents and the child to avoid taking raw vegetables or uncooked meat. The next thing would be you have to prevent infection. So how you can prevent infection? You first thing would be you have to assess if there is any signs and symptoms which is indicating that there is infection, right? And the next thing would be you have to educate the parents. You have to instruct them that they should not give any raw vegetables or uncooked meat to the child. And also you have to stress the importance of hygiene. And then we also have to prevent bleeding in these children. So we have to assess if there is any spontaneous bleeding from the body parts. And also you have to instruct the child to avoid any rough activities which can harm the child or which might increase the chance of bleeding. And then there is health education. So for health education, you have to you have to educate them about the child's condition. You have to educate them that what is the child's current condition, what is the hemoglobin level, and how we should take care of the child. The child is vulnerable to what all those things you should explain it to the parents. And also you should encourage them for genetic counseling and testing. So in case in future, if they if they plan for other child, they should be aware that this condition is there in their family, so they might have another child with thalassemia. So they should be aware of these things. So you have to educate them about these things. Well, so that's all about today's class. So let us conclude our today's topic here. So today we learned about thalassemia, which is a hemolytic disorder where there would be, decreased or reduction of the synthesis of globin chain. Right. So we learned about thalassemia, and we also learned how to manage it. So I hope you have got a better insight about the topic. Thank you.